Hi, I'm Dr. Alavi. I'm a urologist in Fullerton. I've been there 17 years. And I know some of your faces. I don't know others. I was an aerospace engineer. I graduated from Princeton. I worked for NASA for a few months and I quit. And basically, I decided to change my career and I went into medicine. I'm graduate University of Virginia, and I went to residency in University of Miami, where I basically concentrated on laparoscopic and robotic surgery. I do all kinds of surgeries, including prostate cancer. I'll probably be giving that lecture because my partner, Dr. Hughes, is busy on Wednesdays. So the lecture tonight is going to concentrate on incontinence between men and women. Obviously, this affects both men and women and affects as you get older. It's age-related. Incontinence is found in children for different reasons. I'm not a pediatrician or pediatric urologist. But after a certain age, you start becoming incontinent. Usually after fourth decade of life, both men and women can have episodes of incontinence. These can be sometimes when the woman sneezes and they leak, or men have an urgency to run to the bathroom and they leak a little bit. Obviously, the fourth decade of life is not a big deal. They're not really worried about it. But as the decades go on, the incontinence gets worse. So we're going to touch on female and then male incontinence. Obviously, I cannot fit the entire scope of urology into one lecture. So we're going to just touch on the most common subjects and the treatments. So the social impact of urinary incontinence is quite large. Basically, incontinence is an early definition was a sexual thing, but it's not any longer meaning that. It means what it means, basically urinary incontinence. So you can also have stool incontinence, but whenever you talk about incontinence, usually people refer to urinary incontinence. And it affects both males and females, and it can change as the population ages. As I told you, if you go in an 80-year-old population, it's going to find 70% incontinence. And in a 40-year-old population, you probably will find 9% incontinence. I was just talking to a friend of mine. We were at dinner before I came here, and she said she leaks. I was, really? I was shocked because, I consider myself young, but I guess I'm not. So, as we age, and my friends are, I guess, aging, she's incontinent. So I told her I need to evaluate you. And, you come to my office, so I have to probably put you on some sort of pelvic floor therapy and medication if needs be. My sister, who's 52, she's an eye doctor. She has urge incontinence. So yeah, it affects everyone, and it's very prevalent. Now, there's also an annual cost to incontinence. And it's really funny, insurances don't cover diapers, pads, Pampers, and they can't afford it because it's a multi-billion-dollar business. It's funny that so many people wear pads and diapers, but only less than 1% of them see the doctor for it. And I could have thought differently because I'm inundated with patients. I see about 50 patients a day, and we can't keep up. Why is that? Nobody's going into urology because 300 retire every year, 100 graduate. So you can see the numbers. In 10 years, there'll be no urologist you can see for 12 months. So like in the last 5 months, 5 urologists have retired. Only 1 graduated and moved to the community. Dr. Hughes, my partner. So it's extremely difficult to see a urologist. And there are many reasons for that. The residency for urology is extremely long. Same as spinal or brain surgery, no different. It's an extremely long residency. And you both have to keep up with surgical techniques, but we also like medical doctors. We're not like a general surgeon. You come in and we fix your hernia and you leave and you never see us again. And all they have to keep up with is hernia, 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 hernia. We have to be able to diagnose Lyme disease of the bladder. We have to be able to diagnose tuberculosis of the kidney. So we have to be upkeeping with medical at the same time as surgical. And both of them are changing at all times. So hence, it's a very long residency. It's a very competitive residency. Only 100 get in out of the 17,000 medical students per year. And it's more easier to go into plastic surgery, which is 1,000 that get in, than to become a urologist. So one good thing I can tell you is you go to Kaiser, VA, anywhere. Your urologist is the top of the top. I was at the VA in Miami. You're not going to find anyone bad. My other friend who's a urologist, he's a Johns Hopkins grad. There are very few urologists out there, so they're the top of their class. Next, as I was telling you, the cost is unbelievable, but really the treatment cost is 3% and the diagnostic is 1%. What does that mean? Most people think it's normal. They don't see anyone. Same way as normal, your hair turns white. You're not going to see anyone for it except your hairstylist. But incontinence is not really normal. It does affect your life more than your hair turning white. And seeking medical help, it may take 3 months to see the doctor, but it's not life-threatening, but it can be taken care of. Definitely, you can't get any worse. You can only get better. And the worst thing happens is he tells you there's no cure. So you don't lose anything. Ooh. You don't lose anything by seeing the doctor. Okay. All right. And again, rate of diagnosis. Okay, so you can see, let me see if I can figure this thing out. You see how many people are affected? How many people see the doctor? So maybe if they all saw us, urologists would quit. But yeah, so there's a huge discrepancy between how many people have it and how many people don't. What things can cause incontinence? We usually try to break down incontinence into different patterns because it's a lot easier to diagnose if you subcategorize it. Someone says, I go to the bathroom a lot. You ask them, do you have to run? No, I just go a lot. During the night or during the day? They're like, oh, during the day. They're most likely drinking too much fluids. We can do tests. Someone says, no, I get up all night to pee. Ah, that's different. Maybe they have swelling in their legs. And when they become recumbent and their leg comes up, the leg is seen by the heart now and no longer under gravity, and all the water comes back. They make most of their urine at night. Or if they don't have pedal edema, which is leg swelling, they may be missing on antidiuretic hormone at nights. And they're just producing a lot of water. That happens to a little boy that wets the bed. Their brain hasn't matured yet, and they produce a lot of lack of antidiuretic hormone, and they wet the bed. So same thing. What if they run to the bathroom? Urgency. They're like, no, it's not frequent. It's more the urgent. I got to run that bothers me. That's a whole different thing. That's an urgent incontinence. Some people say, oh, I'm coughing and leaking. Maybe they have a dropped bladder. Okay? The GYNs, the gynecologists, try to treat this, but unfortunately they have a hammer. What's the hammer? They only have one treatment, fix the bladder. So they call everything a dropped bladder. So if you have urgency or if you have frequency, dropped bladder, fixing it or not fixing it makes no difference. Not at all. Whether your bladder is over here, over here, over here, over here, over here, your feet are still swollen. But if your bladder is over here, over here, over here, over here, and you have an overactive bladder, which you run to the bathroom, that's a nerve problem. It makes no difference where they put their bladder. That's why we let the gynecologists do their thing, because eventually the patient comes to see the urologist. Because, you know, many patients get unnecessary surgeries, we don't know why, but when you have a hammer, everything looks like a nail. So it's like a chief resident I had, he wasn't the brightest guy, and he used to say, Alavi, I don't know what it is, but it's got to come out. So that was his surgical answer to everything. He took everything out. So, you know, he didn't make it through urology. So the thing is, though, is there's many different ways that we have to diagnose. So it is very important for us to do certain tests. The history is very important to know which tests to do. For example, if your history is, I had radiation, I definitely need to look inside your bladder, and you may need hyperbaric oxygen, high pressure oxygen to heal your bladder after 10 years ago you had radiation. That may be causing your urgency. So the history is very important for us to start looking at things. If you had prostate surgery, then we look at for something else in a man. See how thick his bladder is. Did the prostate enlargement cause his bladder to lose capacity? So the history matters to us. Not that means that we always have a cure, but 50% of the time we can make you a lot better. 50% of the time we can't. There we go. So we're going to talk about female incontinence first. And evaluation of female incontinence is basically the history. And then avoiding diarrhea. That's exactly what I was talking about. If you bring me a piece of paper that shows me you got up 9 times a night, and you got up only 3 times during the day, it's very different than someone that went to the bathroom 9 times and went to the bathroom 20 times in the morning. So two different people, two different diseases. And so it's the voiding pattern matters. A vaginal exam on a woman. Why do we care about the vaginal exam? It's your vaginal vault is dry. I don't even care about a drop bladder. If your vaginal vault is dry because of lack of estrogen, you had menopause 20 years ago, and your urethra is chapped, and you tell me every time I pee it burns, I must have an infection. No, it's like having a chapped lip and pouring lemon on it. It burns because you're chapped. All you need is a cream, and a specific type of cream, Premarin or estrogen. And in 3 months, all your burning goes away. And so will your urgency and frequency. And no, you don't have an infection, and they shouldn't give you 50,000 antibiotics. But that can only be sold if I do a vaginal exam. So the drop bladders, it's only, the GYNs make a huge deal about it. Why? Because that's the only diagnosis they have. So they're looking for a drop bladder. But I really haven't seen an 80-year-old that didn't have a drop bladder. So, it's like saying arthritis. Well, everybody has it at a certain age. So it doesn't really matter. But the vaginal exam gives us a lot of information. Vaginal vault, the dryness of it, how chapped it is. Because the urethra and the bladder are inherently part of your vaginal vault. And in a man, it's totally different. In a man, the bladder and the urethra are made out of a muscle. In a woman, there's not made out of just a pure muscle. They're estrogen-sensitive tissues, which, after menopause, get dry. So whatever's happening in your vaginal vault is happening inside your bladder and the base of your bladder. So the health of your vaginal vault gives me the health of your bladder. Sometimes the vaginal vault becomes so unhealthy that you do get recurrent infections. And the infections are treated with antibiotics after antibiotics. And we see these patients resistant to antibiotics. All they needed was to give a vaginal cream or a laser of the vaginal vault and make the vaginal vault young again. Laser is like chemical peel, laser of your face, same idea. So once you make the vaginal vault young again, good bacteria start to settle down in there, like the GI doctor is going to come talk to you guys about bacteria. So the good bacteria come settle down in there, and the infections will stop. Because it's your bacteria that are giving you your infections. Because they're telling you, I'm not sexually active. You don't need to be. You're getting the infections from yourself. So incontinence is not just pure incontinence sometimes. Incontinence is sometimes associated with infections, associated with dryness. So we have to do a vaginal exam. Cystoscopy and urodynamics. So let's go to history. So history and physical, urine analysis, urine culture, upper tract studies. What does all that mean? Well, if a guy comes in or a woman comes in and they do have a very large drop bladder, the first thing we do is we do an ultrasound. Why do we do an ultrasound of their kidneys? Well, if the bladder is connected to the kidneys through a drainage tube called the ureter, you pull on those things because the bladder is moving down, the ureters are being pulled, the kidneys are being pulled. It is possible they're getting backed up. So we want to make sure, is this an emergency or is this not an emergency? So if the bladder is not causing any harm to the kidneys, it's not an emergency. Okay? So we can take our time and look at it. Urine culture. If you have an infection, you're not going to make it to the bathroom. Okay? Urine analysis. We're looking for blood. Because if you have cancers of the bladder, they usually show up in the bladder as blood. And if you have a cancer, such as called carcinoma in situ, you're going to feel like you're constantly peeing. But that is totally a different kind of peeing than someone with overactive bladder. Carcinoma in situ is a very dangerous cancer that has to be treated. So the history gives us a guidance. The urine analysis in the office makes sure that there's no blood. Urine culture makes sure that there's no infection. And the ultrasound of the kidney tells us there's no damage to the kidney. It's not an emergency. So if the culture is out, the analysis is out, the ultrasound is out, then we can concentrate on the incontinence itself. So it's not cancer, it's not infection, it's not damaging the kidney. So let's think about just what it is. And most common questions now we can talk about. So I dip a urine, I get the culture quickly. We can even look at it on a microscope. So we have pretty much all those answers pretty quickly. So we ask these questions. When did it start? How is it going? Do you run to the bathroom? Do you cough, you leak? Do you leak after you finish peeing? Or before you finish peeing? Some women are morbidly obese. When they sit down at the toilet, their thighs closes. There's no space. They pee to the thigh, goes right back up their vaginal vault. They stand up, it all comes out. Okay? This is called vaginal voiding. And how do they have to sit at the toilet? So if this is the toilet seat, they have to actually straddle it. And their incontinence stops. So we need to know if the incontinence is before reaching the bathroom, after reaching the bathroom. Does it happen all the time? Only after you have spicy food? When is it? How is it? So all of these things come into the use when we do. And you have to measure it. How many pads do you use? Did it get worse? Did it get better? All these things. And that's just a basic history. And the history includes the voiding diary. How much you peed, how many times you leaked, when did you go to the bathroom. And honestly, I've never given a sheet. People usually write it down on their own thing. I say do it Monday, Tuesday, Monday, Tuesday, Monday, Tuesday. 3 weeks in a row. And come back while we do the ultrasound of the kidney and all that to get a picture of what it looks like. So the vaginal vault is basically the anus, the vaginal vault, and the urethral opening. All of these things are interrelated. That's why Kegel exercises to tighten up your pelvic muscles. You tighten up your, oops, I went back, but anyway. You tighten up your anus. This is a woman cut in half. Your anus and your urethra tightens up too. So if I told somebody to do a pelvic exercise, what is called a Kegel exercise or Kegel, how would you tighten up your urethra? It's impossible. You don't know where it is. But if I told you to tighten up your anus, you could. And hold it for 5 seconds. And then tighten up your buttocks. And hold it. And that's tighten up your urethra. Because no one can pee if they're like this. And that's because your urethra is being muscled. And sometimes all you need is pelvic exercise. And there is a good pelvic exercise, basically nurses at Imperial Highway, the rehab center, that we send you to. And they practice as part of St. Jude. And they practice with you and they put some electrodes on you to see what muscles are weak. So pelvic exercise, when we examine you, I'm checking to see those muscles are, how your sensation is. Do you feel me touching you? Does it feel the same on both sides? You know, what am I checking for? Nerve damage, stroke history, MS, anything. So the female anatomy overview is basically, there's a lot of pictures here. What do we do next? Well, we got to do some tests because sometimes we just don't want to give you 15 different meds and see one of them works. We want to narrow it down. So we want to look inside your bladder, okay? So we want to look to make sure there's no bad things, no cancers, no tumors, no polyps. And then we want to also see if there is any kind of injury to the bladder. What else do we want to see? We want to see if the bladder is decreased in capacity. Is it muscular? Is there a blockage? Is there a scar? Is there a stricture? So the cystoscopy, which is like a colonoscopy, it looks inside your bladder, but the difference is it's only 30 seconds. It's a lot easier to do. We do it in the office. We give you some local anesthetic gel, there's no needles, on the urethra where you pee from. We put a small fiber optic lens up and we look inside. So they look like this. These are the old-fashioned ones, which we don't really use these days. These are the metal ones. So when I went through training, these were hot. These were just coming out. And these are long, but don't forget, this much of it goes inside you. That's it. The rest of it is so I don't have to bring my eyeball down to your pelvic anatomy. So basically, it's a very simple tool, and it gives a lot of information. As you can see, this doctor is looking inside, and you can even project it onto a TV. I don't, because people ask me a million questions about the normal anatomy, and I don't have time to teach every patient what normal anatomy is. So basically, we look, and what do we see inside? This is the opening. We want to make sure it's tight. This is a normal bladder. This is looking back. You see this tube has come in and is looking back, making sure the base has got good vasculature. You can see this bladder has got a lot of muscle strands. I don't know if you can see it, but there's a lot of muscles. This person has an obstruction. Okay, so this bladder has become very muscular, and that's why it's lost capacity. So this person has a blockage. What kind of blockage they could have? There's a thing called primary bladder neck outlet obstruction. It's seen in white, petite females, usually blonde, usually lawyers and doctors. And this is a way they relieve stress. And if you ask them, do you grind your teeth? They're like, oh yeah, I grind my teeth. And what happens is that they don't realize it. They pee, but they can't relax their bladder neck, ever. So what happens is their bladder is peeing through a high pressure system, and the bladder starts to becoming more and more muscular, like exercising. You know, it's got to push. So what happens when you exercise? Arnold Schwarzenegger, when he was younger, he walked around like this because he couldn't straighten his arms because he was too muscular. It would just snap back into place. And these people, the bladder is so muscular, snaps. Meaning every time they fill their bladder, before it even reaches capacity, they got to run. That's totally different from somebody who has overactive bladder, which is a nerve stimulation. So these people need a medication to relax their bladder opening. If you give them a medication to relax their bladder, like an overactive person, they can't pee anymore because they need all that strength. So you need to give them yoga so they can relax and not grind their teeth and destroy their bladder. But you got to give them medications to relax their bladder. So we do. So when we profile people all the time, what is profiling? Somebody walks into my office, I look at them, and I look for things. If they're white, petite, and blonde, I'm looking for that, or a disease called interstitial cystitis. If they're, African American, I look for different diseases. We profile everyone in medicine because your genetics you cannot change. So, hence, we basically are looking for diseases when you walk in. So urodynamics is basically an EKG of your bladder. Everybody knows what an EKG is. They go beep, 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 and they see everything. So what is a urodynamics? It's a big instrument that puts a small, tiny catheter in your bladder. It looks like a child's feeding tube. It has a computer microchip on it that measures pressures. And these pressures look like an EKG. And it tells us a lot of things. Basically tells me that the bladder is spasming before the person is even told to pee. Now that's a sign of an overactive bladder. Okay? Now with each spasm, you see some leakage. This person does not have a dropped bladder or coughing or sneezing incontinence. This person has an overactive bladder. So they need a certain types of medication. Now if their sphincter was also doing something funny, then we would tell them, oh, you have MS. You don't have overactive bladder. You need to see the neurologist. And they'll be like, well, I have no problems. I'm like, yeah, you do. It just hasn't shown yet. It's starting in your bladder. So this study gives us a lot of information. So if you're a person with primary bladder neck outlet obstruction, you would see these spasms much stronger, much more muscular bladder, and there'll be no leakage because their neck is so tight, the pressure has to be so high before it leaks. So everybody, you can tell a lot from this study. And usually these are our basic studies to evaluate anyone with incontinence, a urodynamics and a cystoscopy, after we get your history, your physical, voiding diarrhea, urine analysis, and your culture. So the therapeutic option. So a bladder drop, we always put that in just to make our GYN colleagues happy. So basically, if you have a bladder drop, basically the bladder is falling into the vaginal vault. It's really hard to tell, but basically this is the bladder, this is the bottom of the, so the vault is like walking into a room. The ceiling, basically you walk into the room, meaning the woman is lying down, her legs are up, and you walked into the vaginal vault. So you're inside it. The top is the bladder. The bottom is the rectum. The back end, if I keep walking, I'll hit the uterus. And if I walk that way, I'll fall right back out. So the bladder can drop, like the ceiling can just give, or the rectum can push up. So this is a rectocele or cystocele. These are basically hernias inside. On a man, the hernias are very obvious. They pop out inside their abdomen. But the female fascia is so strong, so they can have childbirth. You never hear a woman having a hernia. They could pick up 500 pounds and they don't herniate. What will happen? They herniate inside their vaginal vault because that's their weak point. For men, we herniate everywhere. You pick up something, pop, 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 everything pops. Because our fascia are not strong. We have very strong muscles, but internally we're weak. Women, on the other hand, don't have as strong muscles, but internally are super strong. They could pop a bowling ball out and not have a hernia. And the pressures they create, if a man picked up a weight and had that kind of pressure, he would probably herniate up here too. So we have different ways of herniating. Women have a different way. They usually herniate in their vaginal vault, and those are called bladder drop, this drop, that drop. So repairs we do, and I do them all the time, but only if necessary. I'm not repair happy. So we repair to basically push the bladder up. If the tissue is healthy, we put the tissue together. If the tissue is not healthy, you have to put something foreign, meshes, I don't know, cadaveric fascia. And meshes have a bad reputation because they have caused a lot of problems. So that's basic concept of a dropped bladder. What is the most common thing you find with a person of dropped bladder? It's not that they cough and sneeze and they leak. is that they can't pee, so their bladder fills up with urine and they overflow. What does that mean? They're leaking all the time, walking, talking, moving. And that's called overflow incontinence. Because the bladder has dropped so much, the channel, which is the urethra, which is stuck to the bone, cannot move. So the bladder goes this way into the vaginal vault. If you think the woman's legs are this way, her head is that way. This is her urethra where she pees from, and this is her bladder, a balloon. And then the bladder drops. The urethra is still there. So the urine can't go up and pee. She has to move forward to try to make it pee. So what happens is the urine gets filled up and they have overflowing incontinence. So you need this repaired so they can actually pee to empty. They fill up with urine so much it just leaks out like a faucet that's blocked and all the urine leaks out. So what else could we do? Many times I don't recommend the surgery. Wow, their fascia is not that good. It's older and surgery may not be beneficial. It may come right back in a year because their fascia is not that good. What do I mean? Their tissue is weak. You got to stitch it to something, and if you stitch it and that stitch pulls too, then there is no purpose doing the surgery. So we put a pessary in, and we usually ask our GYN colleagues to do it. Why? They have more time with it, they have more experience with it, and you got to change it every 3 months. We just don't have the time to do this. Okay? So we put a pessary in to push the bladder up so they can pee easier. What is the next thing? Basically, intrinsic sphincter deficiency. So what we were talking about is when you cough, you sneeze, you leak. The most common reason is not a drop bladder. The most common reason is dryness. You need estrogen cream. Remember I talked about dryness and being chapped? All you need is a cream, not a bladder lift. You know, so people come to me with a bladder lift and I got to give them a cream to just fix them, which is ridiculous. They had a surgery for no reason. So the other thing is Kegel exercises. Now, we measure your incontinence based on your cystoscopy and urodynamics. And if it's too much, we're not going to send you for Kegel exercises. I'm going to tell you it's going to take you 3 years before you get better. So we can tell who's going to get better, who is not. And then I tell you, I think you need hormone creams, and then reevaluate, and then do the exercises. And then if it doesn't get better, then you can always do a sling. So, sling surgery, you can't really tell anything, but think of it this way. Sling surgery is a hammock for your urethra. Remember when the urethra was up top near the bone and your bladder is here and you pee through it? If this stretches, this part is still stuck to the bone, this part is down. You leak. You put a hammock under it, that's a sling. That connects it. You don't have to worry about how, but that's just a basic concept. There are many ways to put the hammock. I do hammocks without any incisions on your abdomen because you recover as a 40-minute surgery, you go home. But the recovery is so fast, I got to tell the patient, don't do anything because they feel fine. So the thing is, that's a hammock, that's a sling, and that will take care of leaking. But that's not my go-to. My go-to is exercises, pelvic floor exercises. Hormone therapies for a short while to make the tissue rejuvenated, maybe vaginal lasers, and then the sling. The sling is always the last option. Why? I can always sling you, there's no emergency. Okay? But there's many people that don't need the surgery. And I have so many patients, I'm not surgery happy whatsoever. So basically, if you need surgery, you'll get it, but it's not my first option. Second thing is bulking agents. What's a bulking agent? Well, what if the patient is older? She's on a walker. She's not going to be going and playing tennis. She doesn't need a sling for like a 60-year-old needs or a 50-year-old needs. She's 86. And she doesn't want to go under anesthesia. And she doesn't want to have a big surgery. And she doesn't want to do Kegel exercise. She's abdominal. And the hormone cream didn't help. So what do? We stick in the office, we put the cystoscope, we put a needle number, we put this stuff. It looks like collagen for your lips. It fills that channel up, closes it up. So this huge opening becomes that. So how long does it last? A year. That's pretty good for 87. They don't leak anymore when they cough and sneeze and walk around. So that's what we call a bulking agent. Would I do that on a 55-year-old? No. She's going to go jump on a trampoline with her kid. Everything comes out. So, but, so we plan on who we're dealing with and what is their level of activity. Okay? So depending on the level of activity, I do different things. So this could be done on a 55-year-old. It wouldn't help her if she's going to go play tennis. It would definitely help her if she has a sedentary lifestyle. So what is nerve injury? So urge incontinence, so we're hitting basically the big incontinences. So urge incontinence is when you run to the bathroom. It can be overactive bladder, it could be nerve damage, it could be MS, it could be Parkinson's, it could be spinal cord injury. But most common thing is overactive bladder. What is overactive bladder? It's actually coined by the pharmaceutical companies. Pfizer coined overactive bladder. It was commercials that coined it and became a medical diagnosis. It was interesting. So, but they're not wrong. That's the funny thing. But it is. So it was not a recognized disease until a pharmaceutical company had a medication for it. And now it became a recognized disease. So urge incontinence is basically the fact that you run to the bathroom. There could be many reasons for it, but the most common reason for it is overactive bladder, which is part of aging, like saying arthritis. Your bladder has a lifespan. We're all basically machines with a soul. Machines that can fall apart. So today our technology is we can change your knee, change your hip, change your heart. In the future, they'll change everything, and my kids' kids will never die. So then it becomes only problem is your brain function, because your brain will get old, Alzheimer's, and non-functioning. But my kids' kids will never die physically. They'll just reprint them, which is called 3D printing. So what happens is that medication today are going to be replaced with parts, but we cannot replace the bladder. There is no bladder transplant. Anything that's connected to the brain cannot be transplanted. So your bladder is inherently connected to your brain. You decide whether you want to watch the rest of that movie. You hold your urine. You can't decide your heart not to beat. You cannot decide your kidney not to clean. But you decide your bladder. Hence, anything you make a decision on, like your eyes, look this way, look that way, cannot be replaced. They can change the lens, but they cannot pop my eye out, put another one in. So this becomes the limitation of our science today. Our kids' kids will not have any of these limitations. So with these limitations in mind, we can only give you medications or stimulate the nerves. We cannot replace the part. If it was your knee, I would just replace it. I don't need to stimulate it. I don't need to give you medication for it. I would just replace it. But with bladder, I cannot replace it. So I have to work with what I have. So if it works too fast, I got to give it to slow it down. If it works not enough, then I got to give it something to make it work. So these are the concepts behind the medications. So urge incontinence, there's a lot of different ways to basically bring the bladder into function. So we'll get to this picture. Urge incontinence, basically running to the bathroom, is treated with medication. There are medications out there, Detrol, Vesical, Ineblex, Myrbetriq, there's a million of them. These medications try to suppress the activity of the bladder. You got to take them for 3 months, and their side effect profile is not that bad. Then, if it doesn't work, the other option is a Botox, injection of Botox in your bladder. The problem with Botox is it's limited. Maximum you're going to respond is a year. The other option is called InterStim. What is InterStim? Well, you can take acupuncture. Basically, with acupuncture, you basically take a needle, put it in your ankle, back of your ankle, and that nerve controls the bladder. Because it's a nerve that comes off the bladder nerves and goes down your leg. And acupuncturists have used it for a long time. We do basically the same thing in the office and stimulate that nerve with electricity. And that's called electrostimulation of your ankle. Okay? Another one that's common is called InterStim. It's a device, like a pacemaker. So the pacemaker has been around for a long time. We know exactly how it works. It works wonderful. And the pacemaker is placed in your back, underneath your skin, and it connects to the nerves of the bladder. It paces it, like the heart, to stop beating so fast, not to go every 3 hours. So we do a test in the office. You go home with a little beeper, like this that I have here, and you spend 3-4 nights with it. You see if your urgency went down. Sometimes the bladder doesn't work at all, and we have to pace it back to life so they can pee because they have a catheter. And we do that too. So that pacemaker can work both ways. It can slow down the bladder, or it can pace it back to life. Now, pacing it back to life is really easy. Everybody's seen movies, shock, shock, and the person wakes up. That's easy concept. But how is it going to slow it down? Imagine this. If I tapped you in your forehead, you would blink. Eventually, you would stop blinking. And that's what happens. Your body gets used to it. So it taps, taps, taps the bladder more than the bladder wants to activate. and it numbs the bladder. And the bladder won't respond till 3-4 hours have passed. Then it pees. So it won't put you in retention, but it slows down your bladder urgency. So there are steps that keeps going. Basically, if you have urgency, overactive bladder, we try medications. Medications don't work. We try this. This doesn't work. Botox. Botox doesn't work. Interstem. Interstem doesn't work. God help you. So this is basically overall view of incontinence in females. Males is not that different. The anatomy is pretty similar except for the prostate. If you took the prostate out, the male and the female would be the same. The male would have a longer urethra. That's it. But that's your penis. So the thing is though, so the male anatomy, the only difference really is it doesn't get dry. So there's no chappedness and dryness because it's not estrogen sensitive, but it does get blocked because of prostate. So the same concepts go with the male. The only difference is if this is the bladder and this would be the vaginal vault and this is the rectum, in the male, this is the prostate and this is the penis. So most of male problems occur because of two things: prostate enlargement and overactive bladder. Males get overactive bladder too, and it's sometimes hard to diagnose it. It's really easy to diagnose it if somebody has had their prostate removed. They come in with overactive bladder. We know it's like an overactive bladder. We still do all the diagnoses that we do and evaluations that we do for a female. Cystoscopy, urodynamics, things like that. But in a male, you basically are concentrating on an enlarged prostate. What is an enlarged prostate and why does it block it? So think of it this way. That image really doesn't help you because you're not a medical student. So think of it this way. A balloon upside down. You can imagine a balloon upside down. Now put it inside a donut. So a donut is your prostate, and this urethra or the channel goes through it. So your bladder, which is a balloon upside down, is surrounded at its neck by a donut. This donut grows like your nails all your life. Now think about that donut hole. Keeps getting smaller and smaller and smaller, squeezing the bladder neck. Why does it grow? I don't know. God was a great designer. So the thing is though is, it keeps growing and growing and growing. Eventually, if you live long enough, it'll block it. So how many men are going to have prostate problems? Every man, if they live long enough. Is prostate problem a problem of sub-Saharan Africa? Not at all. Life expectancy is 45. They eat the healthiest diet. They're fresh food every day, ample vegetables, and they die at 45. So do not knock Western medicine. So basically, prostate is a problem after age 50. What's the biggest problem today in Shanghai, China? Enlarged prostate. Why? They are living longer. So because they're living longer, the biggest medical issue and actually the most common surgery right now in Shanghai, China is Roto-Rooter, TURP, prostate surgery to open up the prostate. Because men are living longer and longer, a problem they never had before. So as the prostate enlarges, this donut closes. All our medicine is to open the donut back up. You can open the donut by relaxing it, whether you take medications to relax it, medications to try to relax the bladder that's being irritated by it, medications for erections that also relax it, like Cialis. Some people take Cialis every day. Cialis is like Viagra, is for erections. But it actually is FDA approved for prostate. So Cialis relaxes your prostate. Some people take herbal therapies, that, like myself, saw palmetto. It's an herb. It's a root of a plant and berry of a plant and a leaf of a plant. And saw palmetto grows in North Carolina. It actually grows all over the world. And saw palmetto is more commonly used for prostate enlargement across the world than all medications combined. So I take saw palmetto. I mean, it doesn't hurt. So natural remedies, pumpkin seed, this, that. Do I knock them? I don't knock anything. I don't know enough. But I can tell you which one has had studies, saw palmetto. So National Institute of Health, everybody has done studies. So my usual go-to is herbal meds, because you can always get to medicines. Herbal meds, where they don't work, then you go to medicines. At least the good thing about herbal meds is usually they don't have side effects. Then you go to medications, and we usually go slowly through them. And then you go through medications eventually, And behavioral changes, it's really hard to do behavioral changes because you have no idea what you're doing that makes you want to go pee. So, I mean, if you're drinking 16 cups of coffee, well, that's an easy behavioral change to change. But most commonly, that's not the case. So, what if the medications fail? You still can't pee. You've done the urodynamics, you've done the cystoscopy, everything points to the fact that you have a big prostate. And you don't have overactive bladder, you don't have any other diseases, but your prostate is basically closing up your bladder. And you can't get a night's rest. You're weak stream, you dribble, your urine stops and starts. You keep going to the bathroom because you can't empty your bladder. So we got to open up that prostate. So remember the donut. So if you didn't do it with medication, you can do it with surgery. So what is the plan? Again, the same thing. We're not trying to remove the prostate. That's only done for prostate cancer. We do not remove the prostate unless you have prostate cancer. That's a major surgery. Has a lot of side effects. So the only thing we're trying to do is open the donut. Another way to look about it is, think I have an orange, I leave the peel, I take out the fruit. There are many ways you could do it. Simple. Cut you open like a cesarean. Cut your belly, cut your bladder, shell out the prostate, sew everything back up. No different than cut the belly, cut the uterus, take out the child. Same idea. It's a pretty easy for women to handle. Men don't handle it very well. So we have come up with easier things for men because they're whiny. So what have we come up? Most of our surgeries go through the penis because that's the only other way to get to the donut. So transurethral resection of the prostate is the most common, called Roto-Rooter. I don't get paid as much as my plumber, but he says that he gets paid more than me. I believe him. So the TURP is the most common thing. It's plumbing. It's blocked. We go in, we shave it. Now you can do it with a laser, with an electric knife. All these things are fads. The basic concept is they're cutting you. Whether you come with Darth Vader's laser or an electric knife, it makes no difference. Your body doesn't know the difference. Then there's the surgeon's preference. If I'm used to the laser, I do a better laser. If I'm used to a Roto-Rooter, I do a better Roto-Rooter. So this is a great surgery. Whoops, go back. I don't know how to go back. I killed it again. That was a great surgery. Let me see if I can go back. Voila. So, but if it was a great surgery, people wouldn't try to come up with better ones. What's the problem with transurethral resection of the prostate? Side effects. It's a 97% rate of success. The problem is if you have the side effects, you don't care if 97% are happy. You're not. So anytime there's side effects, other procedures come to being. And you must understand, the other procedures are never as effective, but they're safer. So the next procedure is microwave. This one, transurethral microwave therapy. Think of it this way. I can put that same fruit in the microwave and microwave it, and the fruit will dry up and desiccate and dry up. Now, if you have a donut, it will dry up and open up. So microwave therapy is where you come into an office, they give you a Valium, they give you some gel in your penis, they put a small catheter in your penis, they turn on the microwave, and the same microwave you would get in 60 seconds in your house, we give it to you over 30 minutes in your prostate. The catheter has microwave coils on it. It dries up that donut, and it desiccates and opens up, and you can pee. It's not as effective as the TURP, but what's the safety profile of the microwave? It's the safest procedure in the United States. LASIK can't touch it. So I've done 400 of these, never had a problem. How successful is it? 60%. 2 out of 3. My dad did it, didn't help him. So, so I've done it on 48 doctors. Doctors are the worst patients. They want the safest thing. So every doctor wants a microwave. So, so they don't want any risk. So what's the best thing about the microwave? You don't burn any bridges. You can get a Roto-Rooter afterwards. What's the TUNA, transurethral needle ablation? It's a bit more aggressive. Instead of doing that microwave, you look in there with a camera, you stick a needle in the prostate and burn the heck out of it. Stick a needle, burn the heck out of it, and when you burn something, it dries up. So it's the same concept, a bit more aggressive. Obviously, it has more complications. Bleeding, because you're sticking a needle. Pain. So not as good as this one, but better than this one. So that's transurethral. Urolift is the newest one we do. Okay, it's been around for a couple of years. What is it? Imagine that I told you about the prostate. It's a donut. You can think of it this way also. I'm walking down someone's penis, and I reach the prostate. I'm in a hallway. This is the prostate. And somebody has been rude enough to put all these mattresses inside the hallway. I can't move. So I push the mattress and fire a nail. I push the mattress and fire a nail. That's basically your prostate growth, those mattresses. I go again and there's a lot of mattresses. I push nail, push nail. That's what a urolift is. Okay, so it's a lift. It's basically you lift this away and nail it and lift it. It's a 6-minute procedure. You can have it in the office. You can have it in surgery. It's a very simple thing. It is 80% successful. Risks are very minimal. So it's a very, very good procedure. But it's not a 97% success. The risks are bleeding, but not as much as tuna. Definitely more, not as safe as microwave, but much more effective than microwave. So urolift is a very good procedure. I've never had a problem with urolift. I've had an 80% success. What does that mean? 20% of the patients felt like nothing happened. Nothing improved. They don't know I did it. So these are some of the procedures we do to open up the prostate. Now you guys have a prostate cancer talk, and that talk is about removing the entire prostate. That is a whole different thing, and that's to survive. That has nothing to do with urination. Nobody would be crazy enough to remove your prostate just so you could pee easier. Okay? Now, artificial urinary sphincter. So in women, we have a vaginal sling. When they cough, they sneeze, they leak. They can sling them. They can put bulking agents to tighten them up if they're older. In men, we do have some slings, but they don't work really well because the anatomy doesn't allow it. So imagine somebody had some sort of radiation and their sphincter, everything is destroyed. They are leaking everywhere. It's not overactive because they can't respond to meds. It's not a neurological thing, so it's not going to respond to some sort of inner stem. It is not coughing, sneezing, leaking. They're just leaking all the time. Their sphincter, everything is destroyed. So this is an artificial urinary sphincter. Outside universities, my group does the most of these. So we see everyone from City of Hope, because City of Hope doesn't know how to do it. So City of Hope is great at doing prostate cancer surgery. They do a wonderful job. But like any other place that does a lot of surgeries, you have some complications. It's normal. Anyone that you met that said they did a lot of surgeries and had no complications, they're either doing a microwave or you just met God. So basically, whenever you have a surgical procedure, you're going to have a percentage of people that have side effects. One of those side effects after removing the prostate or getting severe radiation, these are rare, but it does happen, is to be floridly incontinent. And one way to fix it, unfortunately, because the tissue damage is so much, whether it was surgical or radiation, you have to create a new tightening device for the male. Now, I could put a sling here like a woman, but it doesn't work very well with men. So we did sling procedures, and I did them. There are slings for men, but they still leak. I don't know why, but their anatomy is not as great like a woman's. So with a man, we literally have to put a little thing around the channel of the urethra. This is not around your penis. This is only around the channel of your urethra. And then we put a little thing, and you push a button. This opens up. Water goes in here. You pee. Water goes back in there. It closes. And that's an artificial urinary sphincter. We don't do that in a woman. In a woman, you do not have a penis. There's nowhere to place it. We put a vaginal sling, okay? Or a bladder lift, or whatever you guys are used to. So the thing is, though, but this is done in men. So this would be more one of the more aggressive surgeries for men. I do a ton of these. So, I mean, it's nothing big deal as far as I'm concerned. It's an outpatient procedure. So, and it's all done through the scrotum. So it's not a big surgery. But this is something that would happen, extreme case of incontinence in a man. That's pretty much it. Any questions? So the question is, when you do a Roto-Rooter, how long does it last? Is it temporary? Excellent question. Because the prostate keeps growing. I didn't take out the prostate. And it keeps growing and growing and growing. A Roto-Rooter is 10 years. None of the other ones are 10 years. But if you do a tuna, a urolift, a microwave, you can always do a Roto-Rooter. Even with the staples in you, you can do a Roto-Rooter because you shave it all out. So there are medications. The question is, drugs like tamsulosin, Flomax, all these medications that relax the donut, you can only take so much of it. Almost all our medications today control receptors. So if you have high blood pressure, they can give you one medication and raise it and raise it and raise it and raise it until it controls your blood pressure, and then you get all its side effects. Or they can give you 3 of them, each of them at a low dose, and that will control your blood pressure, but you don't get all the side effects. because now 3 are given, all of them at a low dose. So unfortunately with prostate, there is no 3 different ways you can bring the blood pressure down. The prostate pressure is only brought down one way, to open it. So tamsulosin is one of them, Flomax. There's a million of them, Rapaflo, Uroxetrol, Alfuzacin, Cardura. There's all of them do the same thing. They all relax your prostate. All of them do it in one way, so you can't combine them. So if you double or triple them, you get all the side effects. What is the side effect? You lose your blood pressure, you pass out, you hit your head. So those medications are limited. How long is their limit? Usually 5 years, and you need to increase the dose or get another medication with it that works differently. Saw palmetto is the natural treatment of the prostate. The question is, can you take that forever? Saw palmetto is an excellent plant, and no one knows anything about it. There are berries and leaf to the plant. The leaf, when it's concentrated, in the United States, you buy it as a capsule. In most countries, you drink it as a tea, like a tea leaf. In the US, if the berries are concentrated, you see it as a gel cap, which is liquid in it. Some people respond to the gel cap. Some people respond to the leaf. How does it work? Nobody knows. There's a lot of things on the internet that they act like they know, but they don't know anything. So if the urologists don't know, I don't know how Google people know. So Google people will tell you it works like this or works like that. I'm like, really? Wow, these guys know more than I do. So the thing is, the question is, how long can it work? We don't know how it works, so we don't know how long it works. How much can you take? There was only one study out of NIH. The NIH said if you take more than 1,000 milligrams a day, all it does is cause you stomach upset. So lower than 1,000 milligram, divided in 2 doses, seems to work the best. So the people that took it had less emergency room visits, less infections, less retentions, less difficulty with urination. So I personally take the gel cap, which is the concentrated berries. I take it twice a day. I take about 300 in the morning, milligrams, 300 at night. Do I have a brand for you? I don't care, whatever brand you prefer. And I went through 4 or 5 different ones. This one works best for me. How do I know it works? Well, I don't get up at night and I don't piss off my wife. That's how I know it works. Because the moment I don't take it, she reminds me I didn't take it. Because we have a 3-month-old and she does not want to wake up. Okay, so if I wake her up, it's like death. Because she's already worried about the baby. If I wake up, I don't exist. So I should I have to be in that house as if I don't exist. So I sleep like it. So in fear. My wife is not here. So I'm telling everything. So the thing is, so basically you take it twice a day. You take it up to 500 milligrams. My father takes it 3 times a day, a different brand, 320, 320, 320. My brother takes it. We all have enlarged prostate. It runs in the family. What things cause enlarged prostate? Living long enough. Red meat, processed meat, burgers, hot dogs. You know, genetics. Some people are born with it. My father has a humongous prostate. What else you can diagnose someone with enlarged prostate? Hair loss. Male pattern hair loss. I told you, we profile people. Somebody walks in. My dad has no hair, so I know his prostate is bigger than mine. So that same hormone that makes you lose your hair is the same hormone that makes your prostate go through life faster. It's called dihydrotestosterone. So there is a medication along with Flomax called finasteride or dutasteride that shrinks this prostate by not allowing dihydrotestosterone to get to it. And it does shrink it in 2 to 4 years. So if you come to my office and you have a huge prostate, even if you respond to Flomax and you're willing to take the medication and its side effects, I start you immediately on the other medication to shrink it. But first thing I try is saw palmetto if you are not having any major issues. What is major issues? I ultrasound you and you're retaining a ton of urine. Well, you're not going to go with saw palmetto. You're going to need medications immediately because your kidney's under pressure. So again, we adjust it, but there are medications to shrink it. Green light. Yeah. So the question is there a green light laser? And if you remember, I said you can do a transurethral resection of the prostate or a Roto-Rooter with any device you want. I said you could use Darth Vader's laser. You can use an electric knife. You can use a green light. All of them are the same. Why? Well, if I have never done a green light, I'm going to suck at it. So it's the surgeon dependence. Green light is supposed to be at the same frequency of red blood cells, so you have less bleeding because it burns at the same thing. But again, it's surgeon preference. I do an excellent job of TURP, never had a transfusion in 17 years, so I wouldn't do green light because I do a very good job of TURP. So if somebody has never done TURP and they have done green light and you like green light, go to them. But again, it's surgeon preference, because you got to think of it this way. All it is a knife. Now you can call it a laser, electric, a blade, I don't care. You know, a moil does a better job of circumcision than most pediatricians. And a moil just has a little alcohol and it's done. I mean, and they're like better than pediatric urologists. I mean, who would I recommend for child circumcision? A moil, because they got a ton of it. They don't have anything fancy, but they're good at it. So it's really surgeon dependent. So is it green light better than this one? No, it's surgeon dependent. I wouldn't say any of them are better than the other one. If it's your preference, you like the things you read about it, go for it. But make sure you find a surgeon that does a lot of green light. So because, why does this, what is the male hormone dihydrotestosterone? So some men have testosterone. Some men depend on dihydrotestosterone. It's just the way their genetics is. Testosterone gives you sex drive. Dihydrotestosterone gives you sex drive. But if you're the subset of men that need dihydrotestosterone and I give you finasteride, you have no sex drive. That's the number one thing. What's the second thing that happens? Your hair grows back up. That's also known as propecia. And a lot of younger people, so finasteride was discovered for prostate enlargement. It became a multi-million-dollar industry for hair growth, propecia. So its side effect is it makes you grow hair. So these are the two main side effects. Sex drive goes to 0. Hair growth increases. For men, some women that have hair loss may have dihydrotestosterone production. So they can see their endocrinologist. That's the hormone specialist. Also, there are 2 medications to basically cause this hormone blockage from that dihydrotestosterone not forming. One is called Proscar or finasteride or propecia. One is called Avodart or dutasteride. So that's the question. Was there another medication? Yes, there are 2 medications. One is finasteride, one is dutasteride. Which one is better? Dutasteride is a bit more better. There are reasons for it. And it's effectively more effective, but it's more expensive.
What does it do?
Same thing. It blocks the conversion of testosterone to dihydrotestosterone, which is basically, in some men, it causes a promotion of growth of the prostate.
Different from the saw palmetto.
Yes, totally. Some people think saw palmetto, it works that way. But that's in Google. There has never been any studies like that. Why? Dutasteride takes 6 months to 9 months to work. Saw palmetto works within a week. So there's no way it would be the same. You stop dutasteride, your prostate doesn't grow immediately. It takes a year or 2. You stop saw palmetto, within 3 weeks, you're back into where you were. Nobody knows what saw palmetto does. You can take them both. Yeah. They're not related. Any other questions? Thank you all.
Thank you.